morning, everyone, ladies and gentlemen. I'm greatly flattered, actually, standing here as the moderator to host the second session. This second session is more focusing about the functional monitoring as well as the prevention of the vital organs perioperatively. It's a rather big topic, and also it's developing so enormously within the recent years. And those sessions include some very much innovative techniques on this topic, as well as the clinical practice. So I'm greatly honored to introduce our first speaker, Dr. Wang Dongxin, talking about the prevention of post-operative delirium, some of the new evidence. Thank you, Dr. Wang. And let me introduce Dr. Wang. Dr. Wang Dongxin, I know Dr. Wang for a while, actually, long term. Professor Dongxin Wang is the chair of Department of Anesthesiology and Critical Care Medicine of Peking Union First Hospital, and currently supervises more than a dozen graduate students. And Professor Wang is vice president of the Chinese Society of Cardiothoracic and Vascular Anesthesia, executive member of the Council of Chinese Research Hospital Association, branch of anesthesiology, chairman of the Chinese Society of Anesthesiology, branch of sleep medicine, and vice president of Beijing Society of Anesthesiology. And I see Dr. Wang's a superstar, fruitful, publishing 204 papers. That's amazing. So thank you, Dr. Wang. And I will also, should I introduce two reviewers for this topic later? Okay, later, okay. So please, Dr. Wang, thank you.
Thanks, Dr. Hongxi, for the presentation. And dear Professor Huang and dear colleagues, good morning. In the next 20 minutes, I will discuss some progress in the prevention of postoperative delirium. This is a hot topic among anesthesiologists. I will discuss several questions. The first question is choice of anesthetics, which is better, inhalational anesthesia or intravenous anesthesia. Since a long time, anesthesiology realized that choice of anesthetics has impact on the quality of recovery. For example, in this recent meta-analysis, this analysis included 12 high-quality randomized trials with more than 1,400 patients compared. These trials compared inhalational anesthesia and intravenous anesthesia. The outcome, primary outcome, is emergence delirium. The results of meta-analysis showed that patients given intravenous anesthesia has lower incidence of emergence delirium. When compared with emergence delirium, anesthesiologists and also patients are more concerned with the quality of cognitive recovery. In this meta-analysis, it included 10 randomized trials with more than 2,300 patients. These old patients went cancer surgery and general anesthesia. And these trials compared inhalational anesthesia and intravenous anesthesia. We note that most of these trials have a relatively small sample size. The result of meta-analysis showed that post-operative cognitive dysfunction, the incidence did not differ between the two kinds of anesthesia and anesthetics. Regarding post-operative delirium, the number of trials comparing the two anesthetic methods is relatively less, and the results showed that no significant difference between the two groups. One discussing delayed neurocognitive recovery, we note that patients given intravenous anesthesia has relatively lower incidence of delayed neurocognitive recovery. There are also some retrospective studies. This is a recent big data analysis. The study included more than 730,000 patients, older patients, and going general anesthesia. And some of these patients were given total intravenous anesthesia, and others given inhalation anesthesia. The authors performed a propensity score matching. The result shows that patients given intravenous anesthesia developed less postoperative delirium. So we note that studies comparing inhalation anesthesia and intravenous anesthesia is still limited, and the conclusions cannot be reached right now. So further studies are required. This is a recent multicenter trial performed by my group. We enrolled more than 1,200 old patients and going major non-cardiac surgery. We randomized these patients to propofol-based intravenous anesthesia or sevoflurane-based inhalation anesthesia. Our primary outcome was postoperative delirium within the first 7 postoperative days. So our results showed that patients given in intravenous anesthesia developed significantly less postoperative delirium, and postoperative delirium decreased by about 1/3, which is clinically important. Further analysis showed that decrease of postoperative delirium mainly occurred at the first postoperative day. This is also clinically important since the prevalence of delirium was the highest on the first postoperative day. So accumulating evidence showed that when compared with the inhalation anesthesia, propofol-based intravenous anesthesia may decrease the incidence of postoperative delirium. So intravenous anesthesia should be considered in high-risk patients. The second question is intraoperative temperature management. We have long realized that intraoperative hypothermia is harmful to our patients. However, intraoperative temperature management is still not optimal, even recently. This is a recent study, national study led by Professor Wang. The study showed that intraoperative temperature decreased along with time of surgery. And in this study, 44% patients developed intraoperative hypothermia, and the incidence increased along with time. Again, the study showed that intraoperative hypothermia is harmful to patients because these patients who developed the intraoperative hypothermia stayed longer in PACU, stayed longer in hospital, and required more ICU admission. Other studies showed that patients who developed intraoperative hypothermia developed more wound infection and have high volume of bleeding and required more blood transfusion. So intraoperative hypothermia is harmful. Anesthesiology also knows that intraoperative hypothermia have impact on anesthesia emergence because hypothermia affect both pharmacokinetics and pharmacodynamics of anesthetics. This is an observational study published 3 years ago. We enrolled more than 900 patients, older patients, who underwent general anesthesia and major surgery and were admitted to the PACU after surgery. We monitored the occurrence of emergency delirium. We also during PACU stay, and we also monitored the occurrence of postoperative delirium during the first 5 days after surgery. Our results showed that the development of hypothermia at PACU admission is independently associated with increased risk of emergency delirium. And emergency delirium is independently associated with an increased risk of postoperative delirium. We know that postoperative hypothermia is a result of intraoperative hypothermia. Indeed, in this secondary analysis, we found that intraoperative hypothermia is independently associated with an increased risk of emergency delirium. We therefore performed a randomized controlled trial. We enrolled more than 550 old patients and going major non-cardiac surgery. We monitored the occurrence of emergency delirium at 10, 20, and 30 minutes after activation. We also monitored the occurrence of postoperative delirium. In our patients, one group was maintained managed according to a targeted temperature management strategy. That is, intraoperative temperature was maintained within 0.5 degree within baseline. In another group, routine care was performed. And intraoperative targeted management significantly reduced the occurrence of intraoperative hypothermia. And our results showed that patients given targeted temperature management developed significantly less emergency delirium. They also tended to have lower incidence of postoperative delirium, although the difference was not statistically significant. So we found that targeted management which prevents intraoperative hypothermia may be helpful to reduce emergency delirium and also postoperative delirium, but further evidence are required. The third question is intraoperative dexmedetomidine. Dexmedetomidine is a hot drug among anesthesiologists. Several meta-analyses showed that perioperative administration of dexmedetomidine is helpful to decrease the occurrence of postoperative delirium. For example, this recent meta-analysis included 13 randomized trials with more than 4,000 patients. The results showed that both intraoperative dexmedetomidine and intra and postoperative dexmedetomidine decrease the incidence of postoperative delirium. And the effect is significant in older patients. However, we also note that some trials reported a neutral result. For example, in this randomized trial, it enrolled more than 400 old patients undergoing major surgery. One group was administered dexmedetomidine during surgery, another group with placebo. The results shows that intraoperative dexmedetomidine did not decrease the incidence of postoperative delirium. When analyzing these results, we note that in this study, intraoperative dexmedetomidine was continued for 2 hours after surgery. So I suppose that unnecessary dexmedetomidine sedation might be potentially harmful to these patients. These harmful effects potentially counteracted the potential delirium-sparing effect of intraoperative dexmedetomidine. As a contrary, in my study, this is a randomized trial performed by my group. We included more than 600 old patients undergoing major surgery. One group was given intraoperative dexmedetomidine, another group given placebo. Please note that for patients given dexmedetomidine, we stopped dexmedetomidine infusion 1 hour before the expected end of surgery. Our results showed that intraoperative dexmedetomidine significantly reduced the incidence of postoperative delirium and also reduced the occurrence of non-delirium complications. So my suggestion is that when giving dexmedetomidine during surgery, remember to stop dexmedetomidine infusion before the end of surgery. I suggested at least 1 hour before the end of surgery. The first question is dexmedetomidine supplemented analgesia after surgery. We frequently use dexmedetomidine together with opioid for patient-controlled analgesia. In this recent meta-analysis, it included more than 10 randomized trials. The commonly used dose of dexmedetomidine is 0.05 microgram per kilo per hour. And this meta-analysis showed that use of dexmedetomidine as a supplement to opioid patient-controlled analgesia significantly improved analgesia. Pain score at 24 hours and for 48 hours after surgery was significantly lower with dexmedetomidine. And the use of dexmedetomidine also lowered the opioid consumption after surgery and lowered the requirement of rescue analgesics. Considering that dexmedetomidine supplemented analgesia is helpful to improve analgesia and decrease opioid consumption, it is reasonable that we consider that dexmedetomidine supplemented analgesia also decrease the incidence of postoperative delirium. In this randomized trial several years ago, they included more than 550 patients, old patients, and going major non-cardiac surgery. The patients were randomized to receive either dexmedetomidine supplemented PCA or PCA with placebo. Please note that in this study, in this trial, dexmedetomidine was admitted with a relatively higher dose. That means 0.1 microgram per kilo per hour. And the results showed that dexmedetomidine supplemented analgesia did improve analgesia and improve subjective sleep quality. However, dexmedetomidine supplemented analgesia did not decrease the incidence of postoperative delirium. And this low-dose dexmedetomidine slightly increased the incidence of bradycardia, although not statistically significant. So we find that low-dose dexmedetomidine supplemented opioid analgesia improved analgesia and sleep quality, but did not decrease delirium. Why? My hypothesis is that they administered a relatively higher dose dexmedetomidine. That is also a low dose, but it produced sedative effects, and continued sedative effect of dexmedetomidine might be harmful. Counteracted the potential delirium sparing effect of operative dexmedetomidine. For example, in this small sample size trial, the randomized patients after surgery to patient-controlled anesthesia supplemented with either placebo or low-dose dexmedetomidine. The dose of dexmedetomidine is 0.05 microgram per kilo per hour, lower than the previous one. This trial also found that dexmedetomidine supplemented analgesia improved the quality of sleep, increased sleep efficiency, decreased arousal index, and increased subjective sleep quality. The low-dose dexmedetomidine also improved the structure of sleep. However, this dose of dexmedetomidine increased the sedation level of patients. We know that for post-operative patients, sedation is not required. So even with ultra low-dose dexmedetomidine supplemented PCA, although it improved analgesia and improved sleep quality, but it produced sedation. In this recent trial, we investigated that with mini-dose dexmedetomidine, supplemented opioid analgesia, supplemented with mini-dose dexmedetomidine, might also improve sleep quality without deepening the level of sedation. Our results did show that mini-dose dexmedetomidine supplemented analgesia improved sleep quality by, for example, it increased the percentage of stage N2 sleep, decreased the percentage of stage N1 sleep, increased total sleep time, and increased sleep efficiency. However, we note that with mini-dose dexmedetomidine, the pain score and subjective sleep quality did not differ significantly between groups. We did note that with mini-dose dexmedetomidine, the sedation level did not increase because all our patients have a RASS score of 0, no difference between groups. So our results showed that even with mini-dose dexmedetomidine, the supplemented analgesia also improved sleep quality. We also performed a large sample size randomized trial. We enrolled them more than 700 patients undergoing major orthopedic surgery. One group was given patient-controlled analgesia supplemented with mini-dose dexmedetomidine. Another group also patient-controlled analgesia supplemented with placebo. The mean dose of dexmedetomidine is 0.026 microgram per kilo per hour, so it's a mini-dose regimen. Our primary endpoint is delirium within the first 5 post-operative days. Our results showed that mini-dose dexmedetomidine supplemented analgesia significantly improved subjective sleep quality after surgery. It also improved analgesia after surgery because patients given dexmedetomidine supplemented analgesia have lower pain score, both at rest and with movement. We note that patients given dexmedetomidine, mini-dose dexmedetomidine supplemented analgesia have a lower prevalence of post-operative delirium, but the difference was not statistically significant between groups. We also found that with mini-dose dexmedetomidine, it did not produce significant sedation because sedation level, as assessed by Russ, is 0 across all time points of assessment and no difference between groups. And with mini-dose dexmedetomidine supplemented PCA, no significant difference of adverse events between groups. So our results showed that PCA supplemented with mini-dose dexmedetomidine improved analgesia and sleep quality. It may decrease post-operative delirium, but requires further study. Importantly, that PCA supplemented with mini-dose dexmedetomidine did not increase adverse events. In summary, when compared with inhalational anesthesia, we find that propofol-based intravenous anesthesia is helpful to decrease post-operative delirium. And if we prevent the development of intraoperative hypothermia, we might improve the quality of post-operative recovery, decrease emergency delirium. It may also decrease post-operative delirium, but it requires further study. When giving dexmedetomidine during surgery, remember to stop dexmedetomidine infusion prematurely. I suggest 1 hour before the end of surgery. For post-operative patients in general world, we can use PCA supplemented with mini-dose dexmedetomidine. It will improve analgesia and sleep quality without increasing adverse events. Thank you for your attention.
Thank you, Dr. Wang, to give a very much detailed introduction of this topic. Actually, I'm sure there are a lot of messages that we'll take back home. Actually, during my topic in the afternoon, we deal with patients like this, very not similar, but some of trial attempt to prevent this. Now I got some solid evidence from your hard work. Thank you so much. So we'll discuss about it later. May I introduce our second speaker, Dr. Wang E. Her topic is about the research progress and applications of non-contact vital signs monitoring. Dr. Wang E is the professor and chair of Department of Anesthesiology, Xiangya Hospital, Central South University, from the very hot city in China, Changsha. Her specialties is about cardiovascular anesthesia, and Dr. Wang's major scientific achievements including a lot. She's the member of a committee of CSA, member of a committee of CAA. She has more than 10 grants from National Key Research and Development Program of China and National Science Foundation. She published more than 100 papers and won 2 Provincial Science and Technology Progress Awards. So let's join me to welcome Dr. Wang. Thank you.
Thank you. Thank you very much for moderating the session. I'm Wang. I'm very honored to speak here and share the topic of research progress and application of non-contact vital signs monitoring. I'm from Xiangya Hospital, Central South University. I will introduce the research progress of non-contact vital signs monitoring technique and the application in sleep monitoring, perioperative vital sign monitoring, and elderly health management. Currently, non-contact real-time continuous dynamic monitoring technology can be applied to heart rate, breathing, blood pressure, and hemodynamic monitoring. The non-contact monitoring technology is a new monitoring mode and developed from traditional monitoring and portable monitoring. We know the sensors, chips, and digital diagnosis and treatment technologies have given the birth to the new monitoring mode that help integrate the proactive healthcare to daily life scenarios. We know the traditional contact monitoring has some disadvantage, such as many wells and electrodes, poor acceptance, patient mobility restriction, and excessive doctor-patient contact. And the non-contact vital signs monitoring had some advantage, such as no body contact, low transmission power, position and scenarios are abundant, strong penetrate not affected by the clothing and bedding, accuracy meets the medical grade requirements. Now we introduce some research progress of non-contact vital signs monitoring. The most common used technology of non-contact monitoring based on microwave radar. This technology is applied to monitor respiratory circulation to analyze the heart rate variability and has tremendous potential in intensive care, sleep monitoring, and home health care and other fields. But it's also susceptible to interference from noise. The principle of non-contact measurements. When the pulse wave passes through the aorta, it causes vascular vibration, which propagates the surface of the body and can be detected by a radar. The small changes in force and displace on the body surface are detected and achieve the heartbeat and the breath signal capture. And the signal we call the ballistocardiogram. Ballistocardiogram comes from heartbeat and arterial blood circulation. And the cardiorespiratory activity is measured by recording the body's mechanical vibrations. But the accuracy of the signal morphology depends heavily on the sensor's mode and the exact position of the patient relative to the sensor. We often use the force sensor and place on the seat or on the mattress and use it to measure the heart rate and heart rate variability. Non-contact blood pressure monitoring depends on the measurement of pulse transit time, and PTT. Pulse transit time is typically defined as the time it it takes for a pulse wave to propagate between the position in a blood vessel. PTT-based blood pressure measurements are commonly are more convenient and suitable for monitoring in daily scenarios. Using the millimeter reader for non-contact monitoring of pulse wave signal to calculate PTT and continuously estimate the blood pressure is a feasible method. And compared to the peripheral artery transit time, central artery transit time is more stable and reliable. By designing the transmitter antenna parameters of the millimeter wave reader, high signal to noise ratio echo data can be obtained. And the echo data is then processed using spectral estimation, DC removal, template matching, and other algorithms to obtain the signal from the chest and the neck. Extract the characteristics points, calculate the PTT, and then estimate the blood pressure. And we know the algorithm is very difficult for our anesthesiologists. The research demonstrated that the correlation between the changes in the PTT measured by non-contact and contact methods is as high as 0.9. The proposed non-contact measured methods based on the millimeter wave reader has the ability to continuously monitor the changes in blood pressure. There are some research have been published. King's team developed a CW Doppler reader sensor to for non-contactic measurements of human respiration and heartbeat. And the results are very close to manual measurements. In conclusion, the millimeter wave Doppler reader sensor can accurately detect the human heartbeat and respiration. Another researcher have designed a micro Doppler reader with orthogonal structure to detect the human breath. And the device is portable and can be used in a variety of the situations. We also have an authorized pattern for non-contact vital sign monitoring. We collaborate with Nanjing University of Science and Technology to develop a millimeter wave reader equipment for non-contact, non-infection, and comfortable vital sign monitoring, sleep assessment, and cardiac events warning. We are conducting the clinical trials to try to translate the results. And this work is supported by the National Key Research and Development Program of China. Another technology always used for the non-contact measurement is piezoelectric ceramics. The strange gauges made of piezoelectric materials that generate voltage when their shape changes. And this technology can achieve a real-time monitoring of medical-grade high-precision vital signs parameters such as heart rate, respiratory rate, in-bed status, and turning status, and with low cost and easy deployment. Another technology is infrared thermal imaging, ART. And the ART can be used to measure the infrared radiation emitted by the objective. It has a good temperature sensitivity and spatial resolution and non-contact. At present, ART has been widely used in temperature monitoring, fever screen, especially in the COVID-19 pandemic. It's widely used in airport and railway station for the population monitoring. The ART can examine many different aspects of the thermal physiology, diagnosis of injury and diseases such as diabetes, neuropathy, vascular disease, and breast cancer. ART can also be used for non-contact respiratory physiological monitoring by recording the patient's average nostril thermals, detecting the nostril and defining it as an area of interest, ROI, we call it ROI, and using the image processing technology to automatically track the area and obtain the information about the patient's breathing. Photoplasmography imaging, PPGI, is another technology often used for the non-contact monitoring. PPGI can be used to measure the optical attenuation in the skin and to measure the heart rate, the breath rate, and the variability and vasomotor activity. PPGI also is susceptible to ambient lighting, and there should be no obstacle between the subject and the PPGI equipment. And large body movement may affect the accuracy of the results. One study has proposed a camera-based heart rate monitoring technique that estimates the heart rate information from PPGI signal extracted from a video sequence. The experimental results showed that the mean value of heart rate has a very low error and very high 99% accuracy when compared to heart rate calculated from the gold standard ECG, referenced in different conditions of the motion and the respiratory maneuvers. RGB camera, red, green, blue camera, is an optic sensor, is integrated into a camera to monitor the vital signs through the video capture. It's low cost and easy to use, but it's easy to be interfered by the environmental lighting conditions, subject movement, and camera distance, and other factors. Someone proposed and evaluate methods for remote heart rate measurements and use PPG signal extracted from video recordings of subject faces, and extended this technique to improve the accuracy of existing methods. Another study proposed a breathing pattern monitoring system that based on the analysis of RGB imaging. Consider the impact of the user's camera distance and posture and allow the long-term monitoring. Dr. Spot, a robotic system developed by MIT that include infrared and RBG camera for vital signs monitoring, and a tablet for medical interviews. can successfully and reliably provide vital sign measurements and while maintain a social distance. The application in sleep monitoring. Sleep monitoring includes sleep-related vital signs such as respiratory rate, heart rate, pulse pressure, tidal volume, and need to identify the sleep and wake patterns and assess the apnea-hypopnea index. And the important function of sleep monitoring is identify the stages of sleep to make clear, clarify the REM stage, non-REM stage, such as N1, N2, N3 stage. One study present novel real-time technology and technique and estimation algorithm for the non-contact physiological vital sign assessment for chronic heart failure patients based on a patent novel non-contact biomotion sensor. The output of this algorithm compared with a gold standard PSG. The respiratory rate estimation medium accuracy achieved 91%, very high. And the heart rate estimation medium accuracy achieved 91% also. A potential application would be home continuous sleep and circadian rhythm monitoring. A non-contact and cost-effective sleep monitoring system named Sleep Sense is proposed for a continued recognition of sleep status, including bed movement, bed exit, and breathing section. Sleep sensor achieved over 95% accuracy rate in identifying various sleep status and demonstrate wide usability in real life. Another study proposed a tension-based bidirectional long short-term memory, a technique mode for automatic sleep stage scoring using impulse racing ultra wideband radar, which can remote detect vital signs. In results, the researchers achieved accuracy of 82% in the classification of wage stage, REM sleep, light sleep, N1, N2, and deep sleep, which is significantly higher than the conventional network. We are most interested in the perioperative vital sign monitoring. So far, there have been relatively few studies on the application of non-contact vital sign monitoring during the perioperative period. Due to the particularity of the surgical environment, such as the covering of the sterile surgical sheets and changes in the patient's position during the surgery, the application of the non-contact monitoring during the surgery is limited. Future research can focus on reducing the environment interference with non-contact monitoring devices, expanding their clinical application range and improving the feasibility. One study has published and the research design application of camera-based photoplasmography image in intraoperative environment. The sensor was placed half to 1 meter above the head of the patient in the supine position, and the physiological signals were connected through the facial ROI recognition. It was proved it works in the surgery. Another study has published introduced the use of the non-contact monitoring equipment based on infrared thermal imaging to monitor breathing in PACU, and the results proved its reliability. Last, we introduced some application in elderly health management. Elderly health management include chronic disease surveillance, real-time and remote monitoring, and improving home security for the elderly, especially those living alone. Millimeter wave radar can be used for COPD and asthma rehabilitation monitoring. To monitor the number, the cough, asthma attack, severity of cough, and other indicators of user in the room to conduct monitoring and evaluation of the rehabilitation progress of COPD and asthma. Research in Japan has developed an autonomic nerve monitoring system that uses microwave radar mounted on the mattress to monitor autonomic dysfunction caused by chronic disease such as diabetes or myocardial infarction, while measuring the heart rate variability in a non-contact manner. The researchers in China has designed a millimeter wave radar remote monitoring system for the elderly people living alone based on Wi-Fi communication, and constructed the millimeter wave sensor system. The combination of the cloud computing can also realize the real-time and efficient remote monitoring of vital signs of elderly patients living alone, so as to prevent them from accidents. Last summary and the prospect. Compared with the traditional monitoring methods, non-contact vital signs monitoring technology has many advantages and is expected to widely used in home care, sleep monitoring, and other aspects. Its its clinical applications also conducive to the realization of the intelligent medical treatment and the improvement of medical service. Future development direction, the first is multi-sensor fusion and measurement multiple parameters at the same time to achieve comprehensive monitor of the human body. And the most important is to improve the precision and accuracy and strengthen the anti-interference ability to the external environment. Thank you for listening.
Thank you, Dr. Wang, to brought us a really wide vision of what we expect in the future, right? I'm just looking forward to be set free from all the tangled wires around us, all the patients, right? We always been pushed to the corner by all of the machines. Thank you so much.
Thank you.
So let's welcome our third speaker, Dr. Luo Yan. Where are you? Dr. Luo Yan is from the top hospital, Ruijin Hospital in China, of course in Shanghai. And I myself know her more than 15 years, right? We work together on the Chinese edition of Anesthesia and Anesthesia. And this, in addition to all the top titles, Dr. Luo Yan, I know she's from the very authentic French-style hospital in Shanghai, right? I love the corner there. And so Dr. Luo Yan's topic today is about the anesthesia and brain monitoring. Thank you.
Thank you. Just as Dr. Hong has said earlier before this morning, I'm also flattered standing here. And thanks for all of this, making this becoming true for me. And thanks a lot. And today my topic is anesthesia and brain monitor. As we all know that it's a big day for our anesthesiologist. On that day, October 16th, 1846, Dr. Morgan had the public perform a demonstration of ether anesthesia at MIT. And nowadays, this hall is named after Ether Hall. So this is written in his epitaph that before whom in all time surgery was ignored, and since whom science has control of pain. And another big day for not only for the anesthesiologist, but also for our medicine, is that the International Doctors' Day is also in the honor of our anesthetic events. That on that day, the Dr. Cranford Long in his clinic performed the first anesthesia in our human histories. So I'm very proud of being an anesthesiologist. And also, we should make this true. It's quite far away. And we should make become true our vision that we should become a leading discipline, perform the comfortable medical care, and a key discipline that perform the medical safeguard and pivotal discipline to enhance the clinical efficiency of the hospital, and a central discipline that ensure the multidisciplinary cooperation. And finally, we should become as the essential discipline that will recognized by the general public. And that's my dream, hope. And back to our topic today, the brain monitor. As we all know why we should do monitor, because it will improve patient safety and the outcome, and as well as it will reduce the risk of post-operative complications. Is our anesthetic safe enough nowadays? Let's see some data from global and from local. Shall I use this? I can't see from this one. In the 还有 point 吗？有 point 吗？没有。This part is the local data that we can see. Nowadays, our anesthetic-related mortality in China is decreased to 1 in 200,000, and that is the paper from the medicine. That data showed that the overall mortality of perioperative mortality rate is 16 per 10,000 anesthetics. But the interesting thing is that there are no anesthetic-related deaths, which means the patient suffering a death is all by himself, medical conditions, or all by the surgeons, not us. So in this way, the anesthetic is quite safe nowadays. But is it safe enough? Let's see the post-operative complications. These patients live with no regrets, with quality lives. but it is not so gladful. Let's see the postoperative delirium. The abdominal surgery, it also reached high to 51%. And if for the coronary arterial bypass graft surgeries, it is 52. And for the hip fractures, especially for the elder patients, that ratio is reached high to 65. So it is not good enough. And that's why we should pay more attention on our brain functions, and we should to monitor the brain more detailedly. And so I will talk some non-invasive and invasive monitors in brain functions. First of all, as we all know, the electroencephalography EEG, we will use this technique for decades. And it's a non-invasive way to access the depth of anesthesia. And it divides two commercial equipments, that BIS and the Necrotrain. Early in the 1910s, Shanghai Regional Hospital, as well as Peking Union Medical College Hospital and the Guangdong Provincial People's Hospital, we established the Necrotrain Monitor Training Center. So I think 14 years ago. That's the front panel of the Necrotrain. And we can see raw data of the EEG on the top. And we can see the index from 0 to 100. And also it will divide it into 6 stages and 15 levels to show the depth of anesthesia. And we also have the train for the whole procedures of this surgery. And the proper level for our surgery is suggested with D2 to E1, which means the index is 46 to 20. And I will share some cases with our colleagues that since then, I think the precise anesthesia stage has come. And this patient underwent the minimally invasive abdominal surgery and general anesthesia. At the beginning of the operation, the Necrotrain is 30, and at the E0 level, that's the proper level for the surgery. And the heart rate is 70 BPM, and the blood pressure is 90/48. After pneumoperitoneum was established, the systolic blood pressure increased to 155. At that point, most of us will increase the depth of anesthesia. And so the residents did the same thing. And we can see that the Necrotrain index was decreased to 11, and the stage is decreased to F0. That is not the proper stage for our brain function. So the supervisor noticed this abdominal low Necrotrain index. What he did, he analyzed the situation and that the raise of the blood pressure is caused by the stress response from neuroperitoneal compression. So according to the Necrotrain index, he added the antihypertensive drugs instead of the anesthetic drugs, and then decreased the systolic blood pressure and increased the Necrotrain index that make the surgery successfully completed. And so in this case, we can see that the monitoring depth of anesthesia will help anesthesiologists develop a reasonable anesthetic management programs. Especially helps the primary anesthesiologist to establish clear clinical thinking ability. And the case 2, this patient underwent partial pneumoectomy. It's because of the lung cancer. At the beginning of the operation, the NT was E0, also a proper level. And during the operation, the anesthetics observed the decrease in blood pressure and they reduced the amount of the propofol infusion. He found the blood pressure decreased, he shadowed the depth of the anesthesia, and then the Necrotrain goes up to C2, which is 66. It's not suggested for the surgery. So at that time, the supervisor, after checking with the suction capacity, it found it has big blood loss, a large amount of blood loss, bleeding. So it offered, so the anesthesiologist increased the blood flow, the infusion rate, remain the proper infusion rate, and keep the knuckle train in the stable levels proper for the surgery. And so this case showed us that many complicated factors affected the operation. Not only the heart rate, the blood pressure can reflect the overall situation accurately. We should monitor more aspects of the patient, and especially the brain functions. And the third case is the pediatric patient. At the very beginning, we were told that the knuckle train is not suitable for, is only used for adult, not suitable for pediatric, just because no evidence base support the database for pediatric usage. And, but as you know, in Region Hospital, we have lots of babies suffering from burn injury. They will did the skin grafting surgery repeatedly, frequently, sometimes once, 2 to 3 weeks once. So this baby, on his 3rd month, and he did the first skin grafting, the anesthetic is not satisfied with his work. So he asked me, could I use the knuckle train monitor for the following surgeries? I think, why? If we did something good to improve the outcome, to decrease the risk. So I give him the knuckle train, and for the second skin grafting surgery, as in the 4th month of this baby, we can see the data that the similar surgical time, 65 to 70, but the amount of the propofol usage is significantly decreased from 180 to 140. And especially the recovery time is from 40 times decreased to 35 times. So since then, we will use the knuckle train, we will use the brain monitor for all kinds of the patients and all kinds of the surgeries. So that's the EEG. I think with nowadays with the quantitative EEG system, with the artificial intelligence development, the EEG will brighten even more shining in our clinical works and for improve our patients' outcomes. And another non-invasive monitor is the near-infrared spectroscopy. We did some pilot study in this monitor, and we did the surgery, and before surgery we did the end-back tasks, and after surgery in 7 days we did this test again and divided the patients into a POCD group and a non-POCD group. And then we can see that before the surgery, the POCD group have activity was lower during the end-back tasks, especially in the channel 2, 5, 18, and 20, which means is mainly located in the frontal temporal lobe, especially the prefrontal lobe. And that's the activity mapping. The upper group is the non-POCD group, and the lower graph is the POCD group, and we can see significantly difference of their activities. And this is the post-operative. We did the task again. Also, the non-POCD group patients have more activity, especially in the channel 114, 78, and 52, which is also in the frontal temporal lobes, especially in the prefrontal lobe. And so, the end-back task in non-POCD group were better than those in POCD group. That is this pilot study showed us, and which told us that the activity of certain brain regions in the POCD group was decreased during an back task before and after surgery. It mainly located in the frontal temporal lobes, especially the prefrontal lobes. And by the by, we not only did some non-invasive brain monitors, but also the invasive works of this area. We designed and fabricated the microelectric array embedded with platinums and some nano compositions, so it can more detect the electrophysiological signals in certain brain regions in vivid mice. And by collecting the numbers of neuron data for several days, especially in some episodes, we can have a very very flying patterns with functional implications. That is the foresight of this array, and we can see it has with our modification, it have very good performance, which have very low impedance and a very high signal-to-noise ratio. And not only for the electrophysiological signals, but also for the chemical signals. So we modified that array. That paper is published in 2001. And this paper is published in 2002. And this year, we also have a paper just to be proved. And in this array, we modified it into, you can see it's the dual model detection, not only for the electrophysiological signals, but also for the chemical signals. In this case, is the dopamine concentration. And we embedded, fracturated with nanocomposites, and so it also have very good in performance, also very low impedance and very high signal-to-noise ratios in vivid. In this paper, we concluded that the better electrical performance allow this microelectric array to detect electrophysiological signals with a high signal-to-noise ratio, and the better electrochemical performance allow this array to respond with high sensitivity and selectivity to the dopamine concentration. So that's the last slide. As we all know that the famous 122 questions from Science in 2005, what is the biological basis of consciousness? I think these kind of questions also leading us nowadays to make us stick to our actions, to our thoughts, and to our behaviors. Thanks a lot.
Thank you very much, Professor Luo. And I was always joke with my patient that anesthesia is like a cuisine, and yours is just French cuisine, right? Very precisely. So may I introduce Dr. Wang and Dr. Wang Dongxin come over on the stage. Let's open our discussion session. And allow me to introduce our two commenters. Dr. Yu Wenli is the leader of Tianjin Key Medical Discipline in Anesthesiology, Director of the Department of Anesthesiology in Tianjin First Central Hospital, and Professor at the Nankai University and Tianjin Medical University. And our Dr. Gong Yahong, my young sister in PUMCH, and is Associate Professor of Anesthesiology at the Peking Uni Medical College Hospital, and also Secretary of Chinese Society of Anesthesiology, Secretary of Chinese Society of Emergency Trauma Task Force. A lot, okay. Dr. Wang, okay. So thank you.
Okay. First of all, I'll show my thanks to Dr. Huang to invite us to attend this great conference, and also we are thankful for Dr. Liang Hui to organize these great activities. So, and also thank you for all the three speakers to give us these excellent presentations. And first of all, I'll give some comments to the first speaker, Dr. Dongxin. Yeah. As we know, the POD, the postoperative delirium, is quite an issue for us, especially for the patients just undergoing the long-time operations, which is associated with prolonged hospitalization and also some cognitive decline, and also the increasing mortality. So, as Dr. Dongxin said in his presentation, there are quite a lot of investigation that show the factor which is associated with the POD, the delirium. And also, we have found some methods to have the prevention function for the POD. For example, the propofol anesthesia, rather than we use intravenous anesthetic rather than the inhalational anesthetics. And also the body temperature management. For example, we try to avoid the perioperative hypothermia. And also, I think the right time point and the proper dosage of the dexmedetomidine is also very critical for the prevention of the delirium after that. Actually, we are very, as we know that Dr. Dongxin is very famous for your great work, so for publishing a lot of clinical trials in the top journals such as Lancet, BJA, and other journals. So in this occasion, I'd like to invite you to give us some suggestion and show some of your keys to do this excellent work. Please.
First of all, I thank you very much, Professor Yu, for your comment. Yes, it's important to publish our study results in high-level international journals in order that our results can be found by many of our colleagues worldwide. I think the first important thing is that we find an important idea. That means that we are studying a problem. We try to solve a problem that is not answered by current evidence. For example, when we are designing our trial in comparing inhalational or intravenous anesthesia, we find that anesthesiologists are discussing a lot on this topic, but there are insufficient evidence that can achieve a conclusion on this topic. And we also realize that answer such a question is relatively difficult. That means with current instance of postoperative delirium, we will need a higher, a large sample size to achieve a conclusion for these questions. So we need to organize a multi-center trial. That is difficult, and also a multi-center trial is time-consuming. We need several years. As a matter of fact, we need 4 years to complete this randomized trial. So it's important for us to use time, to use to many colleagues we organize in order to complete such a trial. And another important point is that we organize a randomized trial according to widely accepted guidelines, such as CONSORT guideline. That is, we organize a trial with accepted quality. That is a guarantee to do a high-level trial. Last problem is that we should present our paper in high quality level of language. Currently, most scientific papers are published in English, but it's important because English papers, scientific papers, can be reached by our colleagues in other countries. So it's important. And also, when submitting our papers to high-level journals, there are many reviewers, high-quality, high-level reviewers can give many comments. These comments help us to improve our paper. So we learn a lot from publishing papers in these high-level journals. So that's my understanding. Thank you again for your comment.
Thank you very much for sharing your opinions about how to publish high-quality papers. Actually, not only older patients, but also some pediatric patients are suffering from the delirium after operations. So in my hospital, there are quite a lot pediatric patients, children, living donor recipients. They are suffering from the POD. And our team have started to have some work about this. So we are looking forward to have some cooperation with Professor Wang to give us some guidance. And we are looking forward to the future. Thank you very much.
Sure.
Okay, let's, yeah.
Thank you.
Dr. Gong Yahong.
Dear Professor Huang, dear Professor Xu, Professor Liang, and all the other professors, good morning. I'm Dr. Gong from Peking Union Medical College Hospital. And this morning, we've noticed that the two beautiful lady professors have explored the issues of monitoring. Actually, I have a lot of questions for the two ladies, but due to the limited time, I will just pick one question for Dr. Wang E, and I will conserve all the other questions to Dr. Luo Yi, and maybe during lunchtime, okay? So Professor Wang E have told us that non-contact, talked about non-contact monitoring issues. Actually, I think I'm looking forward to having, an intelligence bracelet, bracelet to put on the patient's wrist, and we can have all the other vital signs, especially some advanced hemodynamic modalities. I think I'm looking forward to have that. But as I've noticed, and you have mentioned, actually the non-contact monitoring modalities now mainly focus on the chronic disease monitoring, especially during community settings. So what do you think are the most or the biggest obstacles to apply these non-contact modalities to use in our OR? What are the biggest obstacles?
Okay. Thank you very much for your comments and the question. The main problem of the non-contact monitoring technology used in the perioperative monitoring, I think the main problem is the reliability. The precision and accuracy and robustness of the equipment need to be improved. But I believe this non-contact monitoring technology will be applied in the perioperative monitoring in near far. And I think in the future we will use this technology in the operating room, and the future is coming. Thank you.
Okay, thank you. So you mean that we have a lot to do in exploration of these monitoring modalities, technology especially, maybe. We have much to do, right?
Yeah.
Thank you. Thank you.
Thank you.
Okay, thank you everyone, and thank you all VIP professors around here. And Dr. Huang, would you like any special to address? Okay.
Have a few words to close this session. Okay.
We are going to have more thrilling, interesting topics in the afternoon, right? And thank you for being here and showing our really innovative part of being an anesthesiologist. Thank you.